Today, today we are honored to have Dr. Enitza George, who is the chair of Family and Community Medicine at SUNY Downstate in Brooklyn. She's also a member of the Society for Teachers of Family Medicine Artificial Intelligence Task Force, and she will be presenting her work today on implementing digital and AI for redesigning high-quality primary care in New York City.
Thank you so very much for the invitation and for the privilege, actually, to speak to this very distinguished team.
And so I'll be introducing you shortly. And my name is Sean David. I'm the Vice Chair for Research at Family Medicine and Endeavor Health. And I'm also a clinical professor in family medicine at the University of Chicago. Rachel Brewington is our facilitator, and she's a lead administrator in the Health Outcomes Research Collaborative. And our overall objectives today for this seminar series are to apply AI research to improve health outcomes, to connect researchers and healthcare scientists in Chicagoland, to foster collaboration, and to promote translational research and innovation. And at this time, I'd like to also just thank the leadership at Endeavor Health and everyone working on the front lines to improve the health of our populations, health equity, and to apply translational science principles, including artificial intelligence, to improve the health of our populations. So I am going to, let's go to the next slide, Rachel. So some of the basis for this series are that we believe that it, like many, harnessing AI has great potential to enhance healthcare quality, the health of our communities, and to speed and make more efficient our clinical and translational science. So this spans from areas like medical imaging with more accurate and efficient diagnostic, to pathology, to predictive analytics, to finding out which patients are likely to become septic and moving them into intensive care units, things like that, using algorithms that in real time can help us be more responsive. In personalized medicine, but also in telemedicine, from ambient AI to generative AI, where we can improve our ability to learn. So we hope to cover the landscape in this series. And this is the third of this series, and it's also the 36th in our health outcomes research seminar going back over the last 5 years. So we're hoping that this can be a very robust opportunity for all of us to learn together. Next slide. So today's objectives are to explain why in a city running at New York City pace, our care systems can be smarter, faster, designed for complexity, to emphasize that real people living under real pressure must remain the center of every digital solution and every algorithm, and then to give examples of how these technologies can help us meet patients where they are and keep them from falling through the cracks. Most of our seminars are focused on work across Chicagoland. This is in New York City, the greatest city in the world, I believe. And so we're really excited and honored that we have someone from New York, from Brooklyn, to guide us through the great work that she's doing there. And I think you also have expertise in flatbush diabetes and the fragile type 2 diabetes you were asking about. So we'll talk about that too. So let's go to the next slide. So today's seminar addresses many of the translational science principles that we're trying to advance across our CTSA, the Institute for Translational Medicine. So the creativity and innovation with the work that she's doing with high quality primary care transformation. It focuses on unmet needs in under-resourced or low-resourced communities. Generalizable solutions, it's very cross-disciplinary and efficient, and it's bold and rigorous. It also advances diversity, equity, inclusion, and accessibility, and is definitely very boundary crossing. So this hits on all the marks. Next slide, please. So I'm going to hand this off over to my co-pilot, Rachel Brewington, to talk about CME for today.
Thank you very much. For today, physicians may claim up to 1.5 AMA PRA Category 1 credits based on participation. Other healthcare professionals will receive a certificate of participation, and please check with your licensing board for credit eligibility. Due to a technical difficulty with the CME site today, the CME code isn't available, but will be emailed to you guys later today, along with full instructions on how to retrieve your CME credit. For today's session, you'll be muted during the webinar, but feel free to use the chat to ask questions or share comments at any time. Be mindful of your audience and send messages to both panelists and attendees so everyone can join the conversation. Thank you very much. Back to you, Dr. Tate.
Thank you, Rachel. And stay tuned so you can cash in on the 1.5 AMA credit hours of CME. So here's an overview of the seminar agenda for today. Following this introduction, we'll have our lecture from Dr. George. Then we'll be taking questions from the comments that Rachel mentioned, and Rachel will be reading those to Dr. George for a Q&A session. Following that, we have what I think is a lot of fun is the Beat the Bot, Ask the Professor forum, where we have 3 questions prepared by Dr. George that we are submitting to open evidence, and we'll be able to evaluate the utility of those answers and also discuss those together. Following that, we'll have some closing remarks, and we intend to we are taping this, today, and then post this on our YouTube channel so others who may have missed today can also view the seminar. So without further ado, I would like to introduce, and it's my privilege to welcome Dr. Enitza George. She is Associate Professor and Chair of the Department of Family and Community Medicine. She's also Chief of Population Health, and is the Chief Population Health Officer for that health system at University Hospital at Downstate, at SUNY, Downstate Health Sciences University. So Dr. George, thank you very much indeed for joining us this morning and at your lunchtime. And we welcome your presentation. And
thank
Rachel,
you so much. Again, it really is a privilege to share with you. And I agree with you, New York is the most amazing city in the world with a lot of different challenges. And to get the opportunity to talk to people in Chicago, which is also a great city. I had the opportunity of spending some time in Chicago when I was medical director of a federal plan for the retirees of the Panama Canal. It was physically, the patients were physically in Panama. The management and leadership was mostly in Chicago. So I had a lot of going back and forth from Panama to Chicago. It was interesting doing this hybrid thing where we needed to keep the Panamanian flavor, but make sure that it was federal, because it was a federal plan, make sure that it complied with everything in federal law. So when I was asked to share with Chicago, I said, oh, I have an idea of how things are in Chicago, but some things are particular to New York. And then what I'm hoping to do, next slide, is to share that information and make sure that I give enough that we can all agree on some things that are true for both New York and Chicago. There are no financial conflicts for me, but I do like to tell people that when you hear my presentation, it's not going to be fully medical. There's going to be a lot of geekiness, but I'm going to make sure that the geekiness is not extreme. More importantly, I have a duty as a certified chief AI officer to ensure a proper balance. And I'm hoping that today it doesn't get too geeky, but it definitely has a balance. A lot of people will tell you, next slide, that AI is just the last thing, like the best thing ever. I have a different take on it. I think it's great, but I think that we need to be very cautious, because if we are not participants and if we're not leading the way, specifically in medicine, we can do a lot of hurt. And so my presentation hopes to keep that balance. In a city as magnificent as New York, 8.5 million individuals in a city with 5 boroughs, the iconic bridge is the Brooklyn Bridge, but I must tell you that we have about 22 different bridges. From Manhattan to the different boroughs. Some of them, of course, are for cars and trains. Others are just walking bridges. But regardless, it is very typical, right? We look at this and we say, oh, that's definitely New York. Look at all the high rises. I didn't know, and I learned as I prepared this presentation, that the first skyscraper was actually in Chicago. Chicago actually taught New York how to do skyscrapers, but then we took it and we just made it our thing. And then we did something amazing. The first wire suspended bridge in the world was the Brooklyn Bridge, and that's New York. That's next slide. But if you cross that bridge in any direction, you're going to get a New York state of mind. And that is very important. I live on the Brooklyn side of the Brooklyn Bridge. And it's interesting because I sometimes run on the bridge, and there's several of these signs. It says trouble coping, because in New York, we have a lot of pressure. We're just one subway tardiness away from collapsing. New York Minute is faster than anywhere else. In fact, when you do measurements, there's such thing as a Manhattan measurement, a Manhattan space, and because of the way it's all designed, right? But that does not mean that we're all crazy. We are crazy about what we care about, and we can be very pushy about these things, and yet it is a certain state of mind. Let's go to the next one. Once you cross that bridge, you are welcome to the most amazing place in the entire New York City, for me at least. It's the borough of Brooklyn. And if I can say, I am not an original New Yorker. Like 36% of New Yorkers are not from New York. In fact, 36% of New Yorkers are from another country. I'm originally from Panama. I came to the United States and did my residency here at Downstate. And then I left. I stayed on as medical director of one of the clinics, and then I left to be medical director of a federal plan. And I have been back to Brooklyn about 20 months or so. And there is no place like Brooklyn. I've been in Wisconsin. I've been, as I said, in Chicago, Pennsylvania, Massachusetts. My parents live in Florida. There is no place on earth like New York City. And there is absolutely no place on earth like Brooklyn. They say that the most diverse of all the boroughs is Queens. I have my doubts. I can tell you Brooklyn has 800 different languages without counting all the dialects. We have every possible, people from every walk of life, from people that come from very rural areas to the very super archy-rich. And we have to deal with all of that. And we're all Brooklynites and we're all New Yorkers. It doesn't matter where you are originally from. So it's a beautiful thing, but next slide, it definitely creates a number of challenges. This is State University of New York at Downstate. This is what you're looking at. The first part is the College of Medicine. SUNY Downstate is the only academic medical center in the entire borough of Brooklyn. Remember Brooklyn being 2.6 million people, if I'm not mistaken, the largest city in the entire United States. And in this 2.6 million people borough, there is only one academic center, and that is State University of New York at Downstate. In the back, the other building is University Hospital of Downstate. I'm very proud to tell you that I participated with a group of people assigned by the governor, 9 of us, in a Downstate Community Advisory Board to ensure that we modernized and kept the hospital going, because this community absolutely needs this hospital. It is not a large hospital. We are licensed for about 250, but usually we have a capacity of about 200 or so. But next slide, I want to let you know that this is no small hospital. This is a big deal for this community. A community that is as diverse as I said, but that brings in a lot of challenges. 17% or so of New Yorkers live under the poverty line, and the poverty line for New York is not like anywhere else. You can not necessarily live with about $40,000 or so, 43,000. You will be at poverty levels. In other places, maybe not, but here in New York, even with $80,000, you, a family of 4, may have a rough time. We've talked about the objectives, and I want to tell you why, with so many characteristics, it's so important for us to have a system that is at the pace of New York, that it's not a luxury to have AI and digital health, that despite all of that, we make an effort to look at the individual, not only at the population. And then, as I said, I'll give some balance with talking a little bit about the risks and the responsibility that we all carry here in New York, and of course in Chicago as well, to ensure that primary care is by physicians, for patients, and that we think about how we will be moving in the future. Let's go to the next one. So let's talk about the complexity of New York City and how we need AI and digital health for the demands of this very complex system. Next slide, please. So you would say, well, Chicago, Miami, San Francisco, LA, they do have a lot of crowding, and we do have terrible traffic, probably in LA worse than here. But when you combine all of these things, with a behavioral health crises, with substance use, with people coming from all parts of the world, not necessarily having insurance, worried about ICE and being deported, worried, having all these genetic situations, you will have a community of people that come to you that can be very sick at the time when they come. They will not come just with diabetes, because we have our own flavor of diabetes here. Flatbush diabetes, I'll talk to you a little bit about that. But here, people will come with hypertension, extremely poorly controlled, diabetes, extremely poor control, thyroid disease, extremely poor control, high cholesterol, extremely poor control. And you as a primary care physician will be challenged with deciding, what do I treat first? How do I make sure that this person continues without, a stroke, without a heart attack? Then the interesting part is that you start talking to them and you have to immediately put your own culture in the back burner, because you will be talking with somebody that does not speak your language, does not eat like you, does not understand health the way you understand it, will come with their traditional medicines and ideas of what is health. And that will all challenge you into thinking outside of the box. Let's go to the next slide. And yes, this is true for almost any big city, but in primary care, we have a crisis because we have physicians that are feeling burnt out. We have a lot of turnover. The other day, I was interviewing a doctor to come here, and he was telling me, he was from another system. He says, well, I want to move because, where I am, I'm required to see patients, all day without any administrative time, and I feel burnt out. And I made sure to say, hey, here you might not see that volume, but each patient would be about 3 of those that you might be seeing somewhere else. Because we have a lot of people that may only have Medicare, or may not even have that, may have no insurance at all. This, next slide, is ripe, is perfect, precisely for AI, because AI is excellent at managing big data, data that it doesn't come to you just in writing, but data that comes to you in writing, in video, from pharmacy, from social media, from all the different sources. You have people chatting with their family on WhatsApp about their health, not leaving the city for 2-3 months during the winter to go to the Caribbean and spend their time there. And how is it that they don't get sick over there? They actually get sick when they come back here. So you have to track all of that and give them enough medicine for the 3-4 months that they're going to be out. Or recognize that they may have living quarters instability, so that they're moving from one place to another within the city, not always being so accessible to you as a physician. If you work in New York, and probably it's true in Chicago, next slide, you need to understand that you will not be served. You are here to serve. And so your job is to think every possible innovative way to ensure that your patient is healthy. The consequences of not thinking about the way to deliver care, is a spiral. You will spiral because you will burn out, but there's also a spiral that comes from having the patient waiting for long periods of time, from not being able to give patients an appointment that is congruent with their needs, from having all these care gaps because you cannot find a cardiologist or an endocrinologist for the referral. And therefore, they'll be using the ED for things that are completely preventable. And this spiral will spiral into other patients, will spiral into your life. I'm sure I'm not talking about anything that you don't know, because this is how we create this pajama time, right? 10, 11 o'clock at night, instead of being asleep, instead of being with your family, you are charting because you have a EMR that was created not for medicine, but just for administrative purposes. Next slide, please. And one of my concerns is precisely that AI and digital health have been used basically to modernize what I call legacy flowcharts, or legacy systems of work or systems of thinking. But when we think about digital health and AI, the first thing we need to do in primary care is define it. Are we talking about all these sophisticated apps and where the AI supposedly makes decisions for you, clinical support? That is not what I'm talking about when I talk about digital health and AI, at least not for this conversation. I am talking about automating certain workflows, being able to predict behavior, being able to translate what I am thinking for the patient's benefit so that we can communicate better. Next slide, please. And so as we think about a smarter, a faster care delivery system, what I would invite you to think about is the things that you are already doing. But are they really AI in the traditional way? And where are they moving? Are they moving towards what we're calling agentic AI, meaning that one AI talks to the other AI and actually does something about what you have discovered? So when we think about a traditional AI, for instance, is an AI that may discover from all the data, hey, this patient has high blood sugar, and triggers your attention to call the patient and say, hey, you need to come in, or is reading the patient's email to you and suggesting that you may need to, that should trigger a nurse call within 24 to 48 hours. But when you go agentic, that means that the AI actually takes an action as an agent that is autonomous. I want to say we're not there yet, but there are many systems that are trying for us to get there. Next slide, please. Now, when you're thinking about an urban place like New York, Chicago, Miami, Los Angeles, well, what we really need is something that will help us with all this complexity, and especially something that would help us allocate resources in the best place. Because unfortunately, most hospitals, most healthcare systems have a very thin margin, 1.2%. In the best systems, about 2%. So that the total cost of care, let's say of a patient with diabetes, or let's say hypertension, is not simply the one pill or the one prescription that you're writing. It is everything from seeing the patient in the room, to having the nurse take the blood pressure, to the call that you make to get the patient into the cardiologist, to the echocardiogram, to God forbid the stroke. And it just multiplies and multiplies. But where should you really put your dollars to reduce the total cost of care? That is the type of AI that I am going to be talking more about, understanding the complexity. 8.5 million people. I think Chicago, I read, is about 2.5 or so million people, or something around there. These are no small numbers. If you have all these people with all these different cultures and all these different languages and all these different interests, who is able, better than AI, to manage those? Next slide, please. And so I have good news and I have bad news. The good news is that standard of care continues to be standard of care. The good news is that some of us are interested in pushing the boundaries a little bit, to the point where we get standard of care, some automation, some support, maybe scratch the walls of AI-enabled care, which is completely regulated by FDA. We're not talking about AI going rogue and making decisions, because we're not there yet. And thank God we're not there. And I am one of those proposers that we should never get there. Why? Because I think AI is so powerful that it would start thinking for itself, and we may never even understand what it's thinking, and we may think that we can control it. But I would warn about developing systems that we ourselves don't understand. So are we there yet where AI can be autonomous, independent, agentic in healthcare? The answer is we're not there yet, and I believe we should not even go there. Because it's not about eliminating doctors and nurses, no. It is really about understanding the power of the tools in AI, and establishing strategies that will ensure that we remain in control of what we have created. Next slide. All right, let's go from theory to things that are a little bit more specific. Let's talk about real world examples in AI for diabetes, hypertension, mental health, which are my bread and butter. Next slide. Here at Downstate, and I made sure that there is no logos of some of the systems that we use that support us. Here at Downstate, we have a vendor that helps us, has been helping us precisely with patients that are diabetic, hypertensive, high cholesterol, and mental health. Through AI-powered systems, they're able to track patients, talk to patients, invite them to appointments, even help us at times with care plans. Has it worked? Next slide. Well, it has worked to the point that we have increased our age group payout, meaning that our value-based systems have improved. Next slide. Has it worked in other clinical situations? We have another vendor. We were some years ago not very good in terms of our ratings, and we were having sepsis problems and infections and all of this. Our president implemented and insisted on technology to help us in terms of washing hands. And you would think, you need technology to learn how to wash hands. Unfortunately, this is a reality around the world. And so we implemented this system. Did it work? The good news, next slide, is that it did work. And now we are very proud to say that we have gone from a D to a C to a B. And this is hot, hot, hot from off the presses. And we're very proud because it has taken some time, but more importantly, it has taken a lot of effort. I get daily reports, digital reports of what is going on in my department as chair with the hand washings. And you would think, like, you get reports about how people wash their hands? Yes, because then I have to correlate how they wash their hands with sepsis and with iatrogenic situations in the hospital. And so this has been powerful to help us go from a D to a C to a B. Next slide. And of course, what we want is to go to an A. But why has this worked? Well, I haven't told you that I've been in primary care for 34 years. And I know I don't look that old. I have not that many. I see your hair, Sean, David. I see your hair. You have a lot. And I have some, but not as much. But yes, I've been in practice for 34 years. I remember writing on paper charts. I remember the nursing logs. Like, this sounds like, oh my God, like I'm super old. I'm not that old, but I am old enough to remember where everything was manual and where we had to fight with people. When you automate things, we still fight, but the fight is a different fight. The fight is about the numbers. Like, are you serious? We have such terrible numbers? Yes, humans are very visual. And if I can, in a very objective way, show you that there is a correlation between people that are not washing their hands and our rates of sepsis, things can be a little easier. So that is in part why things are working, but also because it's not only the doctors and the nurses. There's the MAs and the nutritionists and everybody in the hospital. If we're washing our hands, if we're doing all of these different things, and we have dashboards and we can see how these numbers are moving, then you have an objective way, not a subjective way of doing things. And that's part of the reasons why it works. Next slide, please. All right, so now, but how do we take all of that, dashboards, population health, and bring it together so that a person, a real person that is under real New York City pressure is the center of everything we do? How do we keep it patient-centered? Next slide. For that, I'm going to tell you, I don't know if you've been, most of you've been to New York. The moment you get to New York City, either by bus, by train, or by flight, people move at a different speed. Everybody is moving at a speed and talking at a speed, and everything is coming at you. The lights, the cold, the this, the that. You're holding on your purse. You're worried. You know, it's interesting. I don't want to entertain anything, but I've never felt more safe than in New York. And the reason is everybody is minding their own business. Everybody is doing their own thing. And when people start doing crazy stuff, you start watching them and then you go in a different direction. But this is real pressure. Next slide. This is real pressure to the point where it becomes a pressure also for the physician. How do I manage all of these value-based things that, you know, all these requirements? How do I make sure that my patient is actually not going to die because I am stressed out and I have to see them in 2 minutes instead of a whole 45 minutes? How do I make sure that that patient that is outside is not angry? So as a physician, as a primary care physician, you get pulled in so many directions. And all of this translates to a patient that has housing instability, that is late 30, 40 minutes because the train was down, because the bus was down, that has economic stress. No matter how much you make in New York, you're always some level of stress because some bill comes and hits you. And of course, the taxes are not a joke. So how do you help this patient that is under all this pressure and you're on all this pressure? Next slide, please. AI is able to do this precisely as we think about human-centered digital design. If I, as a Panamanian, I speak Spanish, I speak English, but my culture is not going to be exactly the same as somebody from Honduras or Guatemala or Brazil or Venezuela. AI can definitely help me design their care plans based on what I tell it to do in this real world environment that we live in New York, and create, therefore, some trust building. Let's go to the next one. AI will help me spend more time with the patient, developing this trust, even as I can use, an iPad or use a translator. The important thing is making sure that it does not replace the conversation between the patient and myself, and the humility that it takes to do that. Next slide. Precisely, AI can help us do that. So one of the things that I am passionate about is using simulation to help our residents to learn how to speak to patients. For some patients, just all of this moving that I'm doing with my hands, I'm a Panamanian, I'm very expressive, that can be insulting. You can program AI so that it can tell you, right? So let's say I'm speaking to a patient that is Japanese. Just doing this can be offensive to them. But through AI modeling, I can teach my residents how to speak to patients from all of these different cultures. Next slide. What we are doing here in Brooklyn, currently in our Downstate simulation training system, is precisely one of the biggest challenges we have here in Brooklyn is high obstetric mortality. Very complicated patients. And through our simulation training, we help our residents learn how to manage some of these emergencies. Some of it is AI powered, most of it is not, but it is our plan to precisely to advance into all of these different scenarios through precisely using the simulation lab. Sometimes we have these emergencies that don't occur with enough frequency for us to have enough patients to teach the resident. But through the simulation lab, you can simulate different scenarios until you make sure that this resident is competent with what you're specifically trying to get, either by culturally and humility, but also by watching what they write in the chart. You can do sentiment analysis of their charting, of their documentation before the training, and a month, 2 months, 3 months after the training to see what other areas you need to improve. Next slide. As we move forward, then this helps the patient not only feel heard and feel like they're actually the center of their care, but you're also helping in terms of the population. And there's a better balance between what it is that you are trying to do for the patient and what it is that you are required by the system to do for the population. Next slide. All right. Now, how can we help through AI to avoid patients from falling through the cracks? Let's talk about, next slide, flatbush diabetes. It is our flavor of diabetes, a little bit different to most of the diabetes that you may know of. And I'm sorry, I see that some of these slides have moved a little bit, but I think we can all read it. This is diabetes type 2 with a lot of elements of diabetes type 1. These are patients, next slide, that it's called flatbush diabetes because there's a particular area here in New York that is that has a lot of Hispanic and African American and Afro-Caribbean populations that tend to present at 60 years old in DKA, diabetes ketoacidosis, commonly with obesity. Eating this, which is absolutely delicious, is a Jamaican patty with cocoa bread, carb over carb over carb over carb. But it's not only that, because the interesting thing about Flatbush diabetes is that it is a type 2 diabetes, but behaves like a type 1 diabetes, but doesn't have antibodies, and sometimes after the initial presentation does not need insulin, but it's provoked by high levels of stress, very associated with social determinants of health. When the patient leaves to go to their Caribbean island, they are fine. They come back and they get sick again, but this time, not with insulin dependence. Next slide. So it becomes a conundrum. It becomes a stress for the physician to know, okay, so this patient just had a hypoglycemic event, which can be way more dangerous than having a sugar of 300. The sugar now went down to 50. What should I do? Should I take away the insulin? When should I take it away? Should I give them metformin? Can I combine all of these different things? I'm not getting pre-approval for Ozempic or for any of these other medications. What am I, the GLP-1s, what am I gonna do? Next slide. Through AI, we are able to analyze data. We have a team here of endocrinologists and diabetes educators that do research and that are able to message patients even if they are out in the Caribbean. They can work with the patient with their particular dietary preferences, look at their continuous glucose monitoring, check on their weight, talk to them about the fact that you don't have to end up in dialysis or with a stroke or with chop surgeries, and therefore have early detection of which one of these patients are actually going to end up with DKA before they do. Next slide. And through this, we can also detect patients that did not go to fill their medications and call them through the prior digital health system that I mentioned. Connect with them before they actually go to the emergency room, days, predictively, days before a human being would actually be able to notice this. Next slide. Now, what if my culture, well, I'm Panamanian, but what if I were from somewhere else and I have to communicate with this person and I don't understand their special needs? Special not because they're worse or better, they're just different. If through AI modeling, we're able to put in all this information, their labs, the insulin needs, their ethnicity, comorbidities, and we can then predict which patient will require to be on insulin for, say, 6 months before we can then cut down, versus which patient may actually need insulin for way longer, and predict when this patient may become hypoglycemic before it actually occurs. Next slide. We can also automate use their continuous glucose monitoring to decide if this patient may need other things, right? Like, for instance, detecting patterns of their adherence or non-adherence to the medications. Next slide. And more importantly than anything else, the social determinants of health. Brooklyn is, of all the boroughs, the highest where people lose their houses because it is so expensive to live in Brooklyn. We have, I think the last time I saw, about 40,000 homeless people. I remember having a patient with asthma. Bronx is the particular place to have asthma, but, and I'll show you why in a second, but you know, months of giving them all these different medications and the asthma wasn't getting better until we literally sat like, what's going on? He was living in his car. So how, living in your car for the last 2 years, are you going to do all these nebulizations that we were prescribing for you? But if the patient is ashamed to say it, and I'm not even thinking about it, how can I actually help? So through this system, we can then connect the patient with what they need. We are connected with the Arthur Ashe Institute. They have a digital health program where if the patient just has a cell phone, they can go in there, put their zip code, and it tells them where there's childcare, where there is for the pharmacy that has the least price of things, all these different alternatives for them to have better care. Next slide. And of course, if in a place where every block you have a different language, but by using AI, you can actually help this patient to create a diet that is according to their special needs, their special interests, culturally appropriate. And therefore, the physician themselves also learn, remember, this is not the last patient I'm going to see from that culture. It's going to help me with the next patient. Next slide. All right, so of course, it also reduces hospitalizations and readmissions precisely by flagging these patients and optimizing the protocol. Next slide. And just to give a little bit of a futuristic flavor, we're not doing this yet, but remember, this is where we're moving towards digital twins, when we will be able to see what is going on with this patient in their digital twin and try different medications and different solutions and predict and prescribe according to this person's particular needs. Next slide. And of course, all of this helps with the physician themselves because you will feel supported by the system. You will feel like you are not losing the battle with your patients, and that you're not being penalized constantly, being told, oh, look at your numbers are really bad in terms of value-based care, like your blood pressure of the patients is not controlled, which of course makes your blood pressure go up as well. Next slide. And it's important to mention, of course, Queens, it is definitely the borough that has the highest diversity, not Brooklyn. Brooklyn is number 2, the only thing we're number 2 on. But the important thing is that through AI, we can also identify hotspots for different things, for diabetes, for suicide. When it was time, when we had COVID, using AI is exactly how we were able to manage certain things. Next slide. And this alone could be an entire conversation about how the health information exchange system during COVID and even after COVID has helped us with knowing when a patient was hospitalized in a whole other system in Manhattan or in the Bronx. We get that information and are able to then connect the patient with their primary care. It is part of our responsibility through our Medicaid program through health tricks. Next slide. All right. So you have a system with providers, with patients, with data, with wearables. How are we going to do with our next pandemic? And notice I said next one, because New York was the epicenter of a lot of what happened during COVID. But I believe that as we think about what's going to happen next, we can prepare from now so that we're not found uncovered and unprepared for the next time the world gets hit with something, whatever that something may be. Next slide. All right, let's quickly go through the risks. Next slide. And it is a spectrum that we have to understand. We are not at the bottom yet, and we should never get there. But when we talk about software as a medical device, primary care doctors really need to be careful. Next slide. And we need to be careful and we need to be aware. There is a consortium that looks into health and AI and has defined that these are the principles that we should be looking at. Is this AI that is being developed useful? it is fair and equitable? Is it safe? Is it transparent? Is it safe, secure, and is it taking care of the patient's privacy? These are not my definitions, but there is a group of people that are looking into what is going on with AI, specifically in healthcare. Next slide. And you need to be aware, because when we think about this black box and we say, oh, because AI, we can't really understand what's going on in the algorithm or how these decisions were made. I don't think that's what we need to be worried about. Next slide. What we need to be worried about is not what is in the box, but what jumps out of the box. And if that is jumping out of the box is going to get us in trouble. There have been times where AI has been used as psychotherapists, totally inappropriate. Teens that have committed suicide because they've been chatting with the AI and they get enamored with it and start being delusional and have taken their lives. But there have also been physicians that have been charged because through AI, they have up-coded and therefore made some serious mistakes with false claims and overcharging Medicare and Medicaid. Next slide. The question is, how, oh, by the way, this is very recent. In August, our New York general, the lawyer, now my brain left, but introduced new legislation, Attorney General introduced new legislation in the state of New York. You cannot use AI or large language models for therapy without supervision, without specific consent. And I believe Illinois is another one of those states. The question I have, though, is the next slide. How do you consent what you don't understand? If you don't do all the AI training, if you're not familiar with what's going on, how do you actually tell patients, I want you to consent on this? The truth is you don't need to understand everything. What you do need to know is how the AI decision will influence your patient. So in other words, can everybody in this room tell me that they know exactly how an EKG machine works or exactly how each one of the medications we give actually works in a patient? Probably not. But it is our responsibility to understand how our decision will affect the patient. And that is what we are charged with. Next slide. And so it's important to establish governance. It's important to not let our residents and our attendings just go rogue and use whatever new app or whatever new tool there is. There should be a way of regulating, and each department and each institution is charged with doing periodic audits, seeing if the AI is responding properly, or even if you don't think there is a problem, there's got to be a structure where you establish this, and that is the job of a chief AI officer. Next slide. We're almost to the end, but there are a few things that are very important here. And that is, next slide, establishing that strategy. In order to establish that strategy, you need to have three pillars. One that is definitely in medicine, one that is definitely in technology, and the next one that has to do with policies and procedures and prevention, to know when a human being needs to be present and needs to act, even with the AI modeling. So to know when we need to stop whatever is going on. Next slide. All right, and having those guardrails to see when there's bias, to make sure there's transparency, to know that that clinically this thing has been causing this problem even before it causes it. Next slide. And this is the reason. Next slide. This is the reason why I've been saying you cannot just simply use things that you don't understand just because it's a good idea. What I would invite you is that there are several health AI policy and law trackers. I'm not going to give you the names because they're all commercial, but you can look it up just like that. Health AI policy and law tracker. What you want to know as a primary care physician is, as you start using certain apps, is your malpractice insurance going to cover you if there's a problem? Through these health trackers, health AI policy and law trackers, you can see each state. I reviewed it for New York and for Illinois this morning, and I can tell you what is new in each state. And there's some reports that come out quarterly so that you can keep abreast of what's going on and so that you can reduce your liability. Next slide. Finally, there is a need there for structure, for training. We may need to start thinking about differently how we train the medical students and how we evaluate the medical students and the residents based on an infrastructure that we need to build, but we need to be part of that build. Next slide. This is just to share with you that I've created a curriculum specifically for our residents here. Again, you can't use this curriculum because this curriculum is based on our Brooklyn, New York needs, but I would invite you to start creating your own curriculum that is based on your particular needs. Next slide. All right, next slide. Let's just ask a question because people always ask me, can we trust AI? My question is, can AI trust you? Can AI trust you to monitor it, to change it, to make the adjustments, to make sure that it's culturally appropriate? Can AI trust that, like a child, you will not just let it have a tantrum and kick and hurt everybody, but rein it in? I have asked this question to every group that I've given a lecture to. And usually they say, hey, I should not trust me because I don't understand it and I'm not able to adjust it. Next slide. I'm looking at the time, but I do have to tell you about this, and that is the data centers. Even when you say thank you to your chat GPT, it takes thousands and thousands of energy, of water supply, of equipment for that AI to understand and to respond to you. Let's go to the next slide and then to the next slide. And this is important. In Brooklyn, we have, not in Brooklyn, in New York City, we have 70 of these data centers and expanding. They pollute the air, they increase the heat, they use water, and you will find, next slide, not only that people are sick, but also that you will get patients that actually work at these data centers. And it will be your responsibility as a primary care physician to help them with the injuries, with the sense of isolation, with the stress that comes from the noise all night, all day long in the communities. And people will tell you that they're having all these weird symptoms. And unless you ask the question, is there a data center relatively close to you, you will never figure out what the diagnosis is. Next slide. All right, so how do we go from New York to Chicago? And how do we take the lessons learned in New York and we commit for Chicago? Next slide. Well, there are three things that I want to tell you, or three specific things. First of all, you need to learn this. There's no turning around or circumventing it. You need to learn AI. You need to do it because as a physician, if you don't, I am very commonly in rooms where there are only engineers and only software engineers. They will not build for you. They will build around you, and they'll definitely not build for your patients. So you need to be part of that conversation. We also need to understand exactly what's going on. Not because they will replace us. They will never replace us. But they could make us hurt someone if we don't understand what we're doing and we're just using the latest product without understanding what this is about. We also need to make sure that these mistakes just don't go without impunity, so that we need to understand that there's some high impact mistakes. Next slide, please. The other thing we need to make sure of is that these products are actually solving the problems in primary care of fragmentation, inequality, and physician burnout. We need to make sure that these models are trained specifically for the people that are being used. I see sepsis models that were developed in Johns Hopkins, that's beautiful, but Baltimore is not New York City. So we need to make sure that the AI is according to the population that we're working with, and we need to make sure that it strengthens the relationships and doesn't break it down. And the final slide is that we need to, next slide, we need to be the leaders in primary care of what's going on in AI. Final slide is, next slide, and that is, it's not leadership to change things. It's not about putting one thing in one place and moving it around. It's really what we need is transformation leaders, people that are ambidextrous, that yes, provide good medicine, but understand business, that provide good medicine, but also understand systems, that provide good medicine and understand AI. And if we do that, we should be okay. Thank you so much. And I went over 1 minute. Not too bad, not too shabby. Thank you. Happy to take any questions.
Wonderful. Thank you so much. Rachel, would you like to take on the
Sure.
question?
Yeah, we have one question. Oh, we have two questions, sorry. Your diabetes AI example is impressive. Can you explain how this is actually implemented? Is it in the EHR? Do you need to set up a program for each patient in order to obtain the AI analysis?
So the AI program or the specific digital health program that is being used, Dr. Banerjee, Marianne Banerjee, and I can definitely share with you some her contact information. What we do is, well, she has a study going on, but we refer from primary care to her. She's an endocrinologist. She's come many times to give us different presentations through the EMR, but she also has, because she has a grant, she has designated people that support her, and it is a very individualized program that not only speaks directly to the patient and understands their specific needs, does mental health in collaborative care. They have a nutritionist there. And all this information is used, and I believe she's done some publishing. If you look her up as Dr. Banerjee, you could probably see some of what she's done. But yes, it is a combination of digital health, but trust me, very human care. I've had the privilege of hearing how they work this. And yes, part of it is through the EMR, but because they have a grant, they're able to do some digital health as well.
Thank you, thank you. One last question. I feel like AI, from Dr. Susan Fisher, I feel like AI is like a jet plane coming so fast with other healthcare advances that the progress, I believe, has been much slower. I'm not convinced that we have enough expert to get us to the next AI level in care. Are you worried?
I am very worried, but I'm worried for different reasons. So the system where I work is a safety net hospital. Poor patients, not rich system. I worry that our students and our residents are being still trained on outdated legacy systems, and that the bigger and more resource-rich systems are getting ahead of us, and they will be so ahead of us that we will be doing medicine of the past century. I think that we need to worry about the current problems of nutrition, housing, and all of that, and teach our residents these things and our students. But we need to teach them AI, we need to teach them business, we need to teach them systems. We need to help them understand that if you only know medicine, you don't even know medicine. And if we don't do that, we're going to be left behind for sure, which will be a problem both for the patient, but for us as well, because we will not be able to compete in the job spaces. So I think that conversations like these are important. I think that just as we went from just, riding horses to using cars to going on trains and to flying high in jets, we need to do that transition, even if little by little. The HR people need to ensure that all of the hospital system is AI literate. Start there. Start making it that every lecture there is, you start thinking about how could we do this better with AI? If it's only that little question. I love that we're going to do the asking the bot. It is so important to just get people thinking about it little by little. This is not, culture change doesn't happen in a day or two. This has to be continuous. And you're going to find resistors. You're going to have people tell you they don't trust it and it's terrible and it's dehumanizing. But it's inevitable. You cannot escape it. So we have to find ways of making sure that we bring people in. And yes, I am worried, but I'm worried for a different reason.
Thank you. Thank you so much. Okay, Dr. David.
Very much. Okay, let's move to, thank you, Dr. George. That was a very enlightening and covered the entire landscape. And I learned strategically ambidextrous as something that I think we're trying to do too, which is learn everything.
I think I saw a question there.
Yeah. Oh, is there another question? Oh, there is one more question.
Yes, there is another question.
Why don't we go ahead
Sorry
and
about that.
do
One
that?
last question. There has been lots of conversations about the collapse of AI. There was a paper published in Nature that the model collapsed with recursively generated data. Is this a concern within the healthcare space, or is the data continuously being generated?
Oh, it is a concern. Just think about what happened a couple of months ago where everybody's computers were down, everybody's EMRs were down, well, in some places anyway. In the East Coast, for instance, we speak Epic. And whoever doesn't speak Epic may not be speaking, would not be sitting at the table. But that's a huge risk, to be honest with you. This is where maybe variability may be a good idea, but then how do you make sure that you're able to refer out into the system? How do you make sure that the health information systems that there are, you can connect and therefore survive? It is very complicated. Will it collapse? I think that there are some big, big bad actors out there that can influence elections, therefore can influence other things in health. And the worst thing is that in health, you may not be able to even see what the outcome is until it's too late for a patient. There have been some instances where there have been some serious problems with patients not being able to get to care at the right time and get the right service precisely because there was a collapse in the information system. So am I concerned about that? Absolutely. And the beauty of it is that as we go, just like the car, right? When we went from horses to cars, we just didn't go from horses to cars. We went from horses to cars to creating all these new industries. Think about the light posts, think about the GPS, think about tires, insurance companies, detailing companies, and everything that comes with the idea of a car. Well, the same thing is going to happen with AI. And one of the things that is definitely happening right now is AI security, safety. So as a software engineer or as somebody with a master's in AI, you can subspecialize just on AI safety, security. It is a specialty. Do we need that in New York now? There is a chief, I think it's chief informatics or chief security informatics or something to the effect as part of a regulation that we must have. The point that I'm trying to make is as we move forward, industries will open. So when we think about, I've heard some doomsday things of how 99% of people are going to be without a job. I think they're going to have different jobs. I think that we're going to think about things differently. Some jobs disappeared when we went from horses to cars, and some jobs appeared when we went from horses to cars. I think the same thing is going to happen with AI. Collapse as such, no. Transformation, for sure.
I mean, I think, that's a great question too. It made me think about if we're not good stewards of it, then sure, like anything else in life, it can collapse. Be
Yes.
fragmented and purposeless, but with human-centered design, and, empathy built in from the beginning, it can be
Yes.
very different. It's just a lot of front end work to do that.
But we have to do it.
We
And
have
we
to
have
do
to
it.
be part of it. We
And it
can't just
isn't
let
just
it. Yes,
exactly. We don't have there's really no there's shortcuts, but not in the design stage.
correct.
The hope is to free our hands to do more care, what we're
Yes.
good at. So, okay. Wow, this is really a massively important and um, um, mind-blowing topic to take on uh, in a very omnibus way. So let's use our friendly OpenAI, Open Evidence, to pose a question. So Dr. George asks, Open Evidence, what does the latest clinical evidence say about managing patients with ketosis-prone type 2 diabetes or flatbush diabetes? And let's see, the rotor is turning. Okay, here we go. Brief answer, management of ketosis-prone type 2 diabetes involves initial intensive insulin therapy during acute presentation, I assume it during the ketosis stage, followed by transition to oral agents or diet as beta cell function recovers, along with ongoing monitoring for recurrence of ketosis. Long-term management aligns with standard type 2 diabetes care. Individualized medical nutrition therapy, weight management, and physical activity are foundational. Pharmacological therapy should be tailored to comorbidities and risk factors, so the hypertension and other risk factors. SGLT2 inhibitors and GLP-1 receptor agonists are preferred in patients with cardiovascular or renal disease, and metformin remains a first-line agent. So let's go to our internet poll. We have 3 internet poll questions. The first question, rating from 0 to 10, how precise was the AI answer? And how many seconds do we have for this poll, Rachel? Dr. George, you can also do the poll.
Oh, really? Okay.
Oh, I guess you can. I guess we can. Panelists can. Okay.
Oh, I can't? Okay.
No, darn it. Okay.
Okay.
Yeah, I don't think so. We can give them, another 30 seconds,
Okay.
30 more seconds for a minute,
Okay. All right. That should be enough time. Why don't we go ahead and see what the results are, Rachel?
Okay.
Okay. So the number one answer is 5. So it's about,
Yeah.
it's a reasonable answer, not, pretty generic. Okay.
Very generic.
How much did the AI answer expand your thinking? Is the next question. Let's give that a shot, Rachel.
Oh, it's there if you keep scrolling.
Oh, it is there. Oh, they're all there. Okay. Okay, so a little bit better, but 5 to
I
6.
can't see it.
If you scroll down, you can see
Oh, I have to scroll down.
it is. Okay, great.
Oh,
And
there you
then
go. Yeah.
third one, how much did the AI answer help you focus your thinking? And so it's kind of a tie between 5 and 7. All right. Let's go to the next question. Open evidence. What is the strongest evidence for AI-enabled early detection of clinical deterioration in outpatient settings? Okay. Ding, ding. Okay. In summary, the strongest evidence supports AI-enabled early detection of deterioration in hospital settings, which with proven improvements in predictive accuracy in some clinical outcomes. So, yeah, in outpatient settings, robust evidence for clinical impact is lacking, and most AI models remain unvalidated in real-world practice. Sounds like some have been validated in New York City. Fewer prospective studies and real-world trials are needed. Further prospective trials, real-world trials are needed to establish effectiveness in outpatient care. Okay, let's do the poll.
Well, can I ask something before you ask that? I
Mhm.
would ask how many people in this group had heard of flatbush diabetes?
I hadn't until this weekend. So my
Right.
wife has type 1 diabetes, so I really should know this.
All right. So here is an example, right, of what happens when when you have something that is so specialized, quote unquote, because it only apparently happens here in Brooklyn. But the truth is, it does not only happen in Brooklyn. It's just that we call it like that because it's in Brooklyn and Flatbush, Brooklyn, right?
It's fascinating. I really want to understand that fragile ketosis piece. Okay, so poll is going. We have the internet, so let's the internet poll. How precise? How much did it expand your thinking? How much did it help to focus your thinking? Okay. Rachel, do we have some answers?
I do. Here, I can give it 2 more seconds. A couple more people will respond. All right.
Not, not surprising, right?
Yeah,
It really didn't say anything.
lackluster there. Not, yeah. Okay, that had to do, so that with precision was not great. Expanding thinking. Maybe people didn't know that there wasn't much outpatient validation. Um, and then its impact. Okay, so on focusing thinking. So what are your thoughts, Dr. George? Do you think this answer was a
This answer was actually very poor. But if you are in New York, they'll be like, oh, this is 0 or 1. Um, because we are so used to treating this particular flavor of diabetes that we would tell you, oh, all right, so I need to do things that are a lot more specific with these patients. They will not take the metformin the way other patients would take it. And some of them will actually tell you that they were cured from diabetes because their pancreas will recover almost completely. And it's like, are you serious? There's no such thing as recovering. Well, yes, in flatbush diabetes. So it's not something that we are not familiar with. You have to be very careful with treating diabetes here in New York because you can definitely get the patient into severe hypoglycemia.
do you have systems, algorithms where nursing and others can say, here's a vital sign, or here's an eyeball test, and it goes into and says, like, this is a patient that just let's do a on the spot glucose or urinalysis for ketones, and just do you have anything that's going to catch that?
We don't have it as such, but precisely because of the incredible variety and the population that we treat, our brain goes into all those directions. Like, all right, so I need to ask this, I need to see this. This patient is from the Caribbean, is from Trinidad. I'm going to think very differently than if this patient is from, I don't know, some other part of the world, and we get them all. So I don't know that we have algorithms. At least I've never heard that we have specific algorithms. But what I can tell you is that we don't look at diabetes the same way as we looked at diabetes when I was in Massachusetts or in Wisconsin.
So let's see if the bot can do better this time. Okay, let's go to the third question. All right. What implementation strategies are supported by evidence from safely integrating AI into primary care workflows? Good question. Okay. Okay. The most evidence-supported strategies for safely integrating AI into primary care workflows are to engage clinicians, staff, and patients in co-design implementation to ensure AI tools fit real-world needs and workflows, provide robust training and support for primary care teams on AI use, critical appraisal, and communication with patients, prioritize transparency, accountability, and rigorous evaluation of AI systems, including ongoing monitoring for safety, effectiveness, and bias. Address data quality, privacy, equity concerns proactively during development and deployment. Foster collaboration among healthcare professionals, policymakers, and technology developers for coordinated, ethical, and sustainable integration. These strategies are essential for safe, effective, and equitable AI adoption in primary care settings. Okay, I see some smiles. Let's give the poll one more whirligig. Okay, how precise was the AI answer? How much did it expand your thinking, and how much did it help you to focus your thinking? Convergence. All right, I'll give that about 10, 15 seconds. I thought that wasn't bad. Let's see. See how that did. We're getting down to a very loyal group of learners here. Okay, Rachel, let's see, have the big reveal. Okay, it's a little better. So moderately positive enthusiasm for that answer. Okay. In terms of its utility, in terms of its divergence of thinking, not, too much, but in terms of focus, it was pretty good. So I think in that case, what do you think, Dr. George, about that? Did that cover the issues?
Yeah, for us physicians, I think that it definitely did cover. There were a few key words there. If you go back, you'll see it talks about the importance of collaboration, the importance of being part of the design, the importance of training, the importance of looking at the data, the importance of being accountable. These are all precisely what we want to hear in terms of AI. I like to say that there is a difference between having a software engineer or a company gives us a solution that they develop in their, in their computer centers and just spit it out to us and say, well, how can you use this? Versus an answer to a problem that we have agreed upon is important to us and to our patients, because it assumes that there was a question being asked and that we participated in the answering of that question. If we are able to do that more, we'll be a lot better off. The problem is why we spend so much time and we get burnt out by the EMRs and the systems we have is because they were put upon us as physicians. We did not participate in the design of these things.
Mm-hmm.
And we need to prevent that from happening with AI because it will be so much worse, considering how invasive and pervasive AI is and can become as it becomes more and more intelligent. We need to be part of those conversations.
I mean, we really gave up a lot of autonomy for security in medicine, and
Yes.
especially with the medical legal risk issues, and
Yes.
cost us the ability to keep this humanized. And so this is an opportunity to have another shot,
Yes.
another frontier.
And we must do it.
We must do it. Yeah, it's us. It's on us. Okay, let's go to this point here. So first of all, I want to just summarize some thoughts that came to me here. We're both family doctors, and we have translational scientists from all disciplines in our series. But generalist research in some ways takes approaches from multiple toolkits based on the need with a real public health lens, but grounded in our values of beneficence primarily and equity. So here we have an opportunity to do that, and we have no choice. We have to be integrative in how we think about things, and like you said, strategically ambidextrous. And so that reminds us that we don't have the ability to be stovepiped in our thinking. We have to think about those servers, those massive Linux, whatever servers they are, and all the human cost of that, as well as, is this really serving people? Because that ultimately, that's what medicine's all about.
Yes.
serve and support people so that they can um, so they can thrive and live a long, strong life. So, we have no choice but to be very ubiquitous in our thinking and intrepid in how we do it. So I so admire what you're doing, and you're not taking any shortcuts. And you're also maintaining the humanity in this work. So thank you very much. And I think we are ready to conclude.
It was a pleasure being here and sharing with you and learning together. I think that there's a lot of work to be done. I worry, as I said, that we might think this is too geeky. This is not something that that we might think that we can leave this to the engineers. Engineers are super smart. I spend a lot of time with engineers. I love them, but uh, only doctors can do providers anyway, nurses, doctors can do doctors things and think in a certain way because we just don't go to school and get a diploma. We become and we keep becoming. Um, one patient you see is one patient you see, but you change throughout the profession as you get all these interactions and you give more compassion as the profession makes you more humble. That does not really happen in any other profession. We need to protect that, and AI can rip that away from us in a second if we let it.
Well said.
We won't let it.
Thank you so much. And please share your feedback. We have two questions, and this will really help us to know how we're doing and how we can continually improve. So happy Thanksgiving, and
Thank you.
we'll see you out there in the AI world.
Absolutely. Take care. Bye-bye.
Bye, thanks again.
Oh, thank you so much. This was a lot of fun.
Good, good. This was awesome.
Thanks. Bye-bye.
Bye.
Rachel, you got this recorded?
I do.
Great. Okay, I'm going to sign off.
All right.
Thanks again.
Bye-bye.
Bye.